John, I'm going to let Lauren. Lauren can do the honors of introducing you.
Okay. So hi. So you can see his talk. I'm Lauren, and I'm overseeing the internship program this year. So I wanted to introduce Dr. Bartlett. Dr. Bartlett was at Duke in the 1980s when AIDS was first, or HIV and AIDS were first seen in the United States and at Duke. So when Kent Weinhold came to speak with us, he mentioned you a few times because he was kind of on the lab side and you were in the clinic side. So he's going to tell us a little bit about the early days of the pandemic and his observations and maybe how things have changed, over the course of your career treating patients with HIV. And I think you've also done a lot of research on HIV. He's a clinician in infectious disease, so we're excited to hear about your experience and your knowledge.
So actually, before he starts, John co-led FIFA for, I don't know, several decades with Ken Weinhold. So they really spearheaded the whole HIV/AIDS movement in Duke. So we were always super grateful to have you on telling us the story, John. So history.
Thank you. It is always a pleasure to talk to this group. And what I'm going to share with you today is a series of personal experiences and a journey. And so it's quite informal. Please feel free at any point to ask questions. I'm quite easygoing. And if some of my descriptions don't seem clear, please chime in with questions or comments. So the history of HIV/AIDS is a history that follows very closely my professional career. So I'm trained as a medical doctor. I graduated from medical school in 1981. This happened to be the year that the first clinical descriptions of young homosexual men were diagnosed with Kaposi sarcoma and pneumocystis carinii pneumonia. And it happened right about the time that I graduated from medical school. These diagnoses were quite extraordinary. They were diagnoses that we read about in textbooks and principally occurred in people who had severe immune compromise. The fact that they could happen in previously healthy persons was truly shocking. And so this, I can recall reading those original articles and was just astounded. I took care of my first patient who had symptoms of immune compromise in 1982. At that point in time, we suspected that there could be an infectious agent that was causing this clinical syndrome of immune compromise, but we didn't know much about the infectious agent itself. Healthcare workers were, of course, quite scared to take care of these patients. And as a consequence, I think patients suffered terribly. what would happen is nurses were afraid to go into the room. Doctors were refusing care to patients. Patients' meals were left outside of the door to the room because there was so much concern about the potential transmission of an infectious agent that was causing these people to become immune compromised. Quite quickly, we began to see clustering of cases amongst men who have sex with men, amongst injection drug users, and amongst commercial sex workers. And then we started to see cases in hemophiliacs and also amongst Haitians. All of these observations suggested that there could be an infectious agent that was transmitted by sexual contact and blood contact. There had been a precedent for similar risk populations with hepatitis, specifically with hepatitis B and with non-A, non-B hepatitis, which ultimately was identified as hepatitis C. So there was a clustering of cases, and when we began to look at the immunologic profile of these patients, it was notable that they had a depletion of CD4 positive helper T cells. So we began to speculate that perhaps there was an infectious agent that was attacking CD4 cells, and as a result, patients had profound immune compromise. Then in 1983, in France, there were two scientists, Luc Montagnier and Françoise Barré-Senoussi, who had a lymph node from a patient that they cultured, and they recovered evidence of reverse transcriptase activity and had electron micrographs of what appeared to be a retrovirus. But they couldn't sustain the culture of this virus to study it in the lab because it killed all of the tissue culture cells they tried to grow it on. So at this point, Robert Gallo, who was at the National Institutes of Health, had a cell line that was capable of sustaining growth of this retrovirus. And the French group had named it LAV, for lymphadenopathy associated virus, and Dr. Gallo named it HTLV3 for human T lymphocytotropic virus type 3. So it appeared that they might have found the infectious cause of this immune deficiency. Up until that point, it was principally called GRID, which stood for gay-related immune deficiency. So with Dr. Gallo's ability to grow the virus he could develop an antibody test against the virus. And I can recall Bart Haynes, who was at Duke at that time, had begun to work with the hemophilia center at UNC and was testing samples from hemophiliacs for HTLV3, and they were almost all positive. So it appeared that the infectious cause of GRID had been identified, and the syndrome was renamed AIDS, or acquired immune deficiency syndrome. When we saw patients who had AIDS, frequently they had terrible wasting. They had lost 30, 40, 50 pounds in weight. They had multiple opportunistic infections. They would come to the waiting room in clinic and would have to come in on stretchers because they were so profoundly weak. And so it was a very challenging time to provide care. We never knew what to expect next in terms of the complications of AIDS. So for an infectious diseases specialist, it was a remarkable period of time, because we saw infections such as cryptococcal meningitis, toxoplasma encephalitis, disseminated mycobacterium apium complex infection, cytomegalovirus infections. And all of these, up until that point, were not commonly encountered. So we had to try to come up with an approach to clinical care that helped to treat these complications, but we had no treatment for the actual underlying virus infection, what was eventually named HIV, or human immunodeficiency virus. So we started some clinical trials. The clinical trials were mostly focused on how we could help to bolster the immune system. And by and large, they were a complete failure. Then we had a potential antiviral drug that had been developed as a cancer drug at the National Institutes of Health and sold to Burroughs Wellcome. That drug was AZT. I can recall that Kent Weinhold was involved in the testing of AZT and its activity against HIV. So he was sent a series of compounds from Burroughs Wellcome to test them in the lab. And I can recall the very afternoon when Kent came out of the lab and said, John, compound S has activity. So compound S was AZT. So we had the opportunity to participate in a phase 1 clinical trial of AZT at Duke. We administered the drug to patients in escalating doses, which is typical for a phase 1 study. So AZT, as we increased the dose, we began to witness toxicities. And those toxicities included profound nausea and vomiting. And those poor, early, courageous patients who took AZT were so sick. Then we began to see that it could suppress production of red blood cells and white blood cells. And so we had exceeded a safe dose, and we had to come down with a dose. So we thought we had what would be a therapeutic and safe dose of AZT, which was 200 milligrams every 4 hours. What that meant is that patients had to wake up at night to take a dose of AZT. So we proceeded with what was called a phase 2B study. It was a placebo-controlled, double-blinded study of AZT and a placebo. And that study was ultimately demonstrated improvement in the symptoms of patients with what was called AIDS-related complex and AIDS. And it was a fascinating clinical trial. Our patients tried quite hard to become unblinded as to whether they were taking the actual AZT drug or the placebo. And so we had some patients who were chemists, and they tested the melting point of the compounds to see if it was AZT or it was placebo. We had some patients who would participate in parties where they would all bring their study medications, and it came in a capsule, and you could take the capsule apart and pour the powder into a bowl. And so what these study participants did is they had a great big bowl into which they would have a mixture of AZT and placebo, and they would share it with each other. And it was a period of time when people were desperate. There was no treatment. This treatment seemed promising, and so they took desperate measures. Now, if you think about the impact that would have on the clinical trial results, it would tend to attenuate the difference between AZT and placebo. Despite that fact, they still demonstrated a therapeutic impact. So AZT was made available through an expanded access program to patients, and then ultimately had accelerated FDA approval. However, what we began to see is that after a period of time, the benefits of AZT wore off and patients were clinically deteriorating. We suspected that this might reflect resistance of the virus to AZT. As a consequence, we worked with scientists, in particular, Marty St. Clair at Burroughs Wellcome, to do susceptibility testing of HIV to AZT, and we discovered that the virus was indeed becoming resistant. So if one drug led to resistance, we hypothesized that perhaps two drugs could be more potent than one drug and could delay the onset of resistance. And so we had a series of studies looking at two-drug treatment for HIV. And again, we saw more impact on virus, and it lasted longer, but it was still temporary, and two drugs were failed. Now, during this period of time, our patients were continuing to experience decline in health and death. And the median survival after a diagnosis of AIDS was 6 months. So half of our patients were dead in 6 months. And we became quite involved in how to practice palliative care. Our patients were quite afraid of coming into the hospital. If they came into the hospital, they would lose control. They would suffer stigma. It would be difficult sometimes for their same-sex partner to be able to come and visit. The hospital care they received frequently didn't include pain medications, and there wasn't a focus on pain relief. For all of these reasons, we worked with patients to develop a system of home-based care so that people could receive care at home and actually die at home. So myself and our team began to make house calls on patients. And my more senior colleagues thought I had lost my mind in making house calls, that it was going to take up so much of my time. I wasn't going to be academically productive, and I was doomed to fail in academic medicine. In reality, it was just the opposite. In making a short home visit, I could assess the environment in which that patient was living, what kind of support he or she had, what kind of resources would be helpful, and then try to bring those resources to bear. It was challenging because at that time, hospice wouldn't take care of our patients. They felt that if a patient entered hospice care, they shouldn't continue any kind of treatment. So take, for example, we had quite a few patients who had CMV retinitis. They had to receive intravenous ganciclovir 5 times per week, once per day. Hospice felt that was incompatible with their approach to care. And so as a consequence, it took a couple of years for us to convince hospice that preserving sight was essential to quality of life, and that this intervention was not necessarily life prolonging, but it improved quality of life. We also had a challenge in that when our patients died at home, I would go to the home to pronounce them dead. I would call the medical examiner and explain to the medical examiner the circumstances of this patient's death and explain that I was happy to sign the death certificate for the patient. The challenge that we ran into is we couldn't get funeral homes to take our patients who died with HIV. At that time, Duke had a crematorium, and many of our patients wanted to be cremated. I had a pickup truck, so what I started to do is to take patients' bodies from their homes to Duke so that they could access the crematorium. And Duke was happy to help cremate patients. And again, my colleagues thought I was completely nuts and off my rocker, but it was an important service because patients wanted to die in the peace and comfort of their homes. So the next big event that happened was the introduction of protease inhibitors. Protease inhibitors were quite potent, and now we could combine two different classes of drugs, reverse transcriptase inhibitors like AZT and other drugs, along with protease inhibitors. And I can recall the first publications looking at patients receiving protease inhibitors and the huge impact that it had on virus load. At that time, virus load testing by polymerase chain reaction was just coming into the forefront of HIV medicine. So in patients who received 3 drugs, we actually began to see virus loads coming below the limit of detection. This was miraculous. We couldn't believe that this was happening. And in association with this, patients became healthy. They gained weight. They gained strength. They returned to work. I had patients who were receiving hospice care at that time. And at that time, you could only get hospice care if you had 6 months to live. These patients went on triple drug therapy and returned to work. It was absolutely fantastic to see. And this happened in 1995 and 1996. Prior to triple drug therapy, each year, 40% of our clinic patients died. After the introduction of triple drug therapy, the death rate fell to less than 10%. And of course, since then has continued to fall as we have more and more improved treatments. So it was absolutely breathtaking and an incredibly wonderful moment in medical history to see how our patients experienced the benefits of antiretroviral treatment with effective combinations. And of course, critical to that whole effort was good science supported by statistical expertise and robust methods to demonstrate the efficacy of these treatments. So that is my first chapter. In my second chapter, I'm going to take you to sub-Saharan Africa and talk about our work in sub-Saharan Africa. But I think this is probably a good point to stop and see if people have questions or comments.
Yeah, you can.
Just speak up, yes, yeah.
Oh, okay. Thank you so much for that. I have a couple of questions, but the first one is, what is the level of viral load to really say you've attained success? Is there like a minimum level of viral load that you, oh, at this point, this is successful, right?
So the assays have improved with time. The first assays that we used in clinical trials could measure down to 400 copies per milliliter of plasma. Now that assay has moved down to less than 20 copies per milliliter of plasma. So we've seen steady improvement, and you can use ultra-sensitive assays that even go lower. Now, what was interesting about HIV is that we had absolutely no idea how rapidly this virus was turning over and replicating. And so in untreated patients, we could see viral loads up to 10 million copies per milliliter of plasma, which was just unthinkable at the time. But of course, the reverse transcriptase is not an enzyme that works very efficiently. It makes mistakes. And so if you have fast virus turnover with an enzyme that is making mistakes as it goes, that leads to mutations in the virus, which of course can lead to treatment resistance. And so the whole picture began to make sense. And all these things came together, and we had a much better understanding of what was happening with our patients.
Well, I have a question. You said that hospice was resistant to giving pain meds to patients. Is that because of the population they were treating? Why were they resistant to giving pain meds?
So I think there were multiple reasons. I think the first reason is that in the beginning, we didn't have a solid sense of the mortality rate associated with AIDS. It took some time to understand that ultimately, in the absence of effective treatment, people were going to die. Secondly, I think there was some medical voyeurism. We were curious about the kinds of complications that patients could have. And so as a consequence, we focused on the complications instead of the patient's pain. Thirdly, in the 1980s and 1990s, there was quite a bit of concern about prescription of narcotics. So I actually was investigated by the Drug Enforcement Administration, the DEA, because of the amount of narcotics I was prescribing to patients. And so there was a general apprehension. It was a period of time when Brompton's cocktail in the UK and hospice care in the UK had just been described. And there was apprehension about implementing similar systems in the United States. Now, fortunately, things have changed. But if I take you back 30 years, that's what we were dealing with at that time.
And I was also curious, when you were recruiting patients to the clinical trials early on, was there a lot of resistance, or were most patients enthusiastic to enroll? And also, how did that compare to like other studies you did over the course of your career, like in terms of people being enthusiastic about joining trials or research?
So I think overall, patients were highly motivated to participate. I think what encouraged them to participate was a hope that perhaps they could derive some benefit, a sense of altruism, and a commitment to try to decrease the suffering associated with AIDS. You also have to put this in the context of the history of abuse of certain populations, and specifically African American populations, by the medical experimentation system. So the ghost of the Tuskegee experiment followed us as we tried to encourage African Americans to participate in clinical trials. And we had to work hard to try and build trust and for them to have confidence given the past historical abuses that had occurred. But I'd have to say, for the most part, people were keen to participate, and their sense of altruism came to the fore.
Any other questions?
Yes. I just want to know, were there consequences based on your choice of visiting patients, considering the fact that the hospices were not really taking them in? Did you face any consequence for, making that choice?
So I'm sorry, I couldn't quite get, you asked about the consequences of a choice.
The choice to visit patients when you talked about hospitals not taking them in, then you said you want to be home visiting patients.
Home visit?
Mm-hmm.
Did you have any comments to that?
Home visiting?
Yeah.
Oh, you mean when he talked about you pick up the volume?
No.
I think, was there any personal consequences for yourself
Yes.
for deciding to go to do home visits? Did you face any problems in your career?
I found it to be incredibly rewarding. So I timed my visits around the time I was headed into work or leaving work and coming home. And, I think of a career in medicine partially as a clinician and partially as an amateur anthropologist, and understanding cultural differences and how different people live. I had the opportunity to go to patients' funerals, and I found the funeral ritual offered great insight into people's lives. So I felt much more satisfied as a physician by participating in these kinds of activities. Now, of course, you know, I have retired from clinical care, but my patients, 100% of them, when I retired, were healthy. And we were all getting old together. And we could talk about our aches and pains and which medications we're treating our hypertension with. And so I had taken care of people for 20, 30 years. And that was also so fulfilling to have that longitudinal period of time to know people over time. And so that's part of the interpersonal satisfaction that this career, this journey has offered. So perhaps now I'll talk a bit about a big transition that happened, and that was in the year 2000. The World AIDS Conference was being held in Durban, South Africa. And so I had accumulated lots of frequent flyer miles, and my wife and our children came with me to South Africa to attend the meeting. All of a sudden, we saw the contrast between the United States, where our people with HIV were healthy, and sub-Saharan Africa, where there was essentially no access to antiretroviral treatment. And for my wife and myself, that was an epiphany, and we changed our lives and decided that we were going to focus on how we could help to narrow this gross disparity. We had seen how in North Carolina, having a specialized research center could help to provide care to patients and could improve outcomes for patients. And we coined the term research with service. So it wasn't just research for research sake, it was research that was focused in the service of patients to try and offer access to new treatments. We had a previous relationship with the Kilimanjaro Christian Medical Center in Moshi, Tanzania. So I made a trip with Nathan Thielman to assess the interest of our Tanzanian colleagues in trying to build a research effort focused on HIV. And during that trip, we saw exactly what we had seen in the early days in the United States. Patients were coming into waiting rooms in stretchers. The medical ward, 40% of the patients on the medical ward were AIDS patients. And patients were doing horribly. And so we speculated that clinical trials of antiretroviral drugs could help provide access to treatment. So we introduced those clinical trials and began to treat patients. Then President Bush introduced PEPFAR to enhance access to treatment, and the Global Fund to fight AIDS, tuberculosis, and malaria helped to support treatment. And all of a sudden, treatment was becoming accessible to people in sub-Saharan Africa. Lo and behold, They were incredibly adherent with their medications. They took them on time. And as you would expect, Africans got healthy just the way Americans got healthy. And it was fantastic to see this recapitulation of all of the clinical improvements that were happening. Patients had access to treatment, and as an American taxpayer, it made me so proud to see our tax dollars go to such a substantive, incredible program. And so we continued to initiate a series of studies to better understand how we could treat patients in their own country and understand the differences in metabolism of drugs, how patients reacted to drugs, how they accepted drugs. Around this time, the whole field of implementation science was beginning to evolve. So how can you take an intervention from Durham, North Carolina, where it has demonstrated efficacy, and implement that intervention in a different context and study it and understand it in that context? In addition, we set up programs to help offer training to our Tanzanian partners so that they had the skills and knowledge to continue these programs independently. And so I as a corollary to research, of course, you have to have a component of capacity building. And how can you assist with ultimately having the entire operation be taken over by well-trained Tanzanian colleagues? And so that became another focus of my career, is how could we improve research training and clinical education for scientists and young doctors to deliver care so that they can do it independently. And that has been enormously rewarding and fun. So perhaps I'll stop there because I see we have 12 minutes left, and take questions about either the first chapter or the second chapter.
So I just had a quick question. You talked about these long-term treatments that people living with AIDS have to undergo, presumably for the rest of their life. Have you done any work on the sort of side effects that has on the human body with taking these drugs for so long, and is anything being done to kind of counteract?
So it's an outstanding question. With longer term follow-up of patients on antiretroviral treatment, we have seen unexpected long-term side effects. They include things such as bone loss. They can include cardiovascular events. And most of these are specific to specific drugs. In addition, the portfolio of available medications has expanded. So a class of drugs became introduced called the integrase inhibitors. The integrase inhibitors seem to avoid quite a few of these side effects. So that is a positive change. At the current time, we're seeing our population of persons with HIV aging. As they age, they are experiencing chronic diseases such as hypertension, cardiovascular disease, cancers. And so we're having to integrate treatment of these other comorbid conditions into the care of patients. But to come back to your question, yes, there were long-term side effects that we recognized. And fortunately, there has been a continuous improvement in the safety of the drugs that we offer patients. And the current combinations are better tolerated and offer less long-term risk.
So I have a question. So talking about Tanzania, my question goes towards are people in Africa, specifically like Tanzania, are they resisting care? Like, because I know majorly in Africa, people feel somehow when it comes to like taking drugs coming from outside, they used to have mentality that, we don't know what you want to, maybe you want to use us as an experiment or something. So people are always taking like, having that kind of mentality there. So what are those challenges faced during that time? And how were you able to like increase the kind of care and help, and they were able to get it as well?
That is a very perceptive and complicated question to try to answer. So, of course, HIV universally is associated with stigma. Because of stigma, quite a few patients have been reluctant to get tested and get into care. In addition, there are other issues such as transportation, cost, that can come into play. And then there's the issue of trust. And historically, the atrocities of colonialism are fresh in people's minds. So building trust is critically important. Listening to the community, working within local cultural norms is incredibly important. And of course, training indigenous people to deliver the care at the highest possible standard is critically important, because they're going to mistrust foreigners because of the history of colonialism. And they're going to, they may trust in-country colleagues to a much greater extent. So lots of things have interfered with care, and we try to be perceptive and to work within local context and build capacity in local context to deliver care.
Any other questions?
John, just a general question. You've had an incredibly successful career that's helped so many people, but I think it's also notable for the sort of courageous decisions you took, which are kind of unorthodox, like being an undertaker for HIV people, for example, transitioning large parts of a career to serving Africa rather than people in the American community. Like, do you have any advice for us young people on how to make our careers as what life decisions you should make to make as interesting as your life has been?
Oh, thank you, Cleburne. So, it's a journey, and I think you want to follow opportunities that may enhance your worldview. And I think it's fantastic as statisticians that you give people like myself the opportunity to speak with you. And as a statistician, the work that you do to help support research ultimately leads to better care. And I think having that connection to the people who are benefiting is critically important. And take those opportunities to meet people. You know, take, for example, the CFAR research retreat. The community is represented in the people who attend the research retreat. You have the chance to get to know them and to hear from them the impact that science has had in improving their lives. And so follow your heart. And I'm so grateful that my medical training didn't beat my heart out of my chest, and it kept beating, and I followed my heart, and I'm better off for it.
Okay, more questions? Any insights for anyone else?
I have a question for the clinical trial for the efficacy of AZT. So you mentioned that HIV patients, they didn't comply with their treatment assignment, so they kind of struggled with whether or not taking placebo or not. So how do you circumvent the problem? Were you able to use the data at all?
Oh yes, despite this confounder, the placebo-controlled clinical trial demonstrated the efficacy of AZT, and the confounding factors would have had the potential to obscure that difference. So the fact that we still saw a difference and saw efficacy was remarkable, and I think spoke to the therapeutic impact AZT was having, albeit modest and transient. It was a heck of a lot better than the natural history of the disease.
Thank you.
So thank you all for listening. I have an 11 o'clock call, so I appreciate what you do, and work hard and go for it.
Thank you so much.
Thank you. Bye.